యూట్యూబ్ స్టార్ట్ చేసేస్తారా? Good afternoon, everybody. I hope the slides are visible, and I hope the audio is also clear. Yeah, now it is unmuted. So very good afternoon and welcome everyone for this 102nd session of Cuddles online neonatology. We are very grateful for all of you who have joined live and those of you who are joining us on YouTube as well. We are going to continue with the sessions of OSCE in neonatology. So we had already finished 10 OSCEs in our previous session. So we'll be starting from question 11 now. So I begin with the first OSCE for today's session. You're dealing with a 15-day-old preterm baby born at 28 weeks of gestational age with birth weight of 920 grams. This baby is born to a primigravida mother with imminent eclampsia. The mother had received antenatal steroids complete coverage and the baby is currently on CPAP support with OG feeds of 200 ml per kg per day of mother's own milk with HMF. So the questions for us today are, what is the recommended calorie protein intake, protein energy ratio as per ESPGHAN 2022? Sorry about the typo, that is 2022. And we'll also be discussing about standard versus adjustable fortification. What is the recommended calcium, phosphorus, vitamin D and iron requirements, again as per the updated ESPGHAN guidelines. And about the growth chart that gives us prescriptive approach to monitor growth for a baby like this. So let me begin by answering the first question. So for all postgraduates and for all of us who are practicing neonatology actively, nutrition is a very major aspect of our care. And the European Society of Pediatric Gastroenterology and Nutrition, which is ESPGHAN, has come out with 2 guidelines on macronutrient and micronutrient supplementation in preterm low birth weight babies. One came in 2010 and second came in 2022. The other organization that gives nutrition recommendations is the American Academy of Pediatrics Committee on Nutrition. So AAPCON is the other body that gives nutrition specific guidelines. Recently, the NNF clinical practice guidelines, NNF CPG guidelines have also come up with a very practice friendly and evidence based updated guideline on preterm nutrition. So few numbers which we definitely have to remember by heart, there is no other option, would be the macronutrient requirements recommended by the RDAs recommended by ESPGHAN 2022. The calorie intake recommended now is 115 to 140 kilocalories per kg per day, and this is for preterm very low birth weight, that is less than 1500 grams newborns. So 115 to 140 is the recommended calorie intake. Protein intake that is recommended is 3.5 to 4 gram per kg per day. And this needs to be increased to 4.5 gram per kg per day if the baby is ELBW, that is extreme low birth weight. Protein energy ratio, which is the grams of protein that is to be provided for every 100 kilocalories intake of carbohydrate, is 2.8 to 3.6 gram per 100 kilocalories, as recommended by ESPGHAN. Some other micronutrients that we often are asked in the exams and which are relevant for our clinical practice are calcium, phosphorus, iron, and vitamin D. So in terms of calcium, the recommended intake is 120 to 200 milligram per kg per day. This has gone up slightly from the earlier ESPGHAN 2010 guidelines, which was 110 to 140 milligram per kg per day. When it comes to phosphorus, the recommended intake is 70 to 115. The iron guideline, iron recommendation is 2 to 3 milligram per kg per day for a preterm VLBW. And vitamin D, which used to be earlier 4,000 to 1,000 international units per day, it was the only recommendation which did not have per kilogram body weight in its unit. But in the ESPGHAN 2022 guideline, this has also been revised. The number has been revised to 400 to 700 IU. And the unit also has been revised to international units per kilogram per day. But remember that one should ideally not cross 1000 IU of vitamin D daily. irrespective of the baby's weight. So which means if you're dealing with a 1.5 kilogram baby and you intend to give 700 IU per kg, please try to not cross 1000 units daily overall. So if you're giving vitamin D3 800 IU per ml drops, then the maximum intake would be 1.2 ml every day. I can see Sri Salem sir who is logged in. Thank you sir for joining us.
Yeah, thank you, madam. Go ahead.
The reason why we say not to cross 1000 units per day daily is because very high intakes of vitamin D can be associated with nephrocalcinosis, hypertension, and hypercalcemia as well as hypercalciuria. Unless we have a valid indication like in a newborn with neonatal cholestasis, where you suspect that vitamin D absorption can be faulty, please don't cross 1000 international units per day maximal enteral intake of vitamin D. So I repeat important numbers to be remembered: macro and micronutrients. Calories 115 to 140 kilocalories per kg per day. Protein 3.5 to 4 gram per kg per day. And when we say this, if it's a baby less than 1000 grams, you are justified in giving 4.5 gram per kg per day. While telling this, one should also remember that 100 ml of preterm EBM contains 67 kilocalories per 100 ml, and the protein intake, which is very variable, varies in preterm EBM from 1.1 to 1.5 grams per deciliter, and in term EBM it varies between 0.9 to 1.1 grams per deciliter. Protein energy ratio should be 2.8 to 3.6 gram per every 100 kilocalories provided. When it comes to important micronutrients, calcium has been recently revised to 120 to 200 milligrams per kg per day, and phosphorus to roughly 1/2 of calcium. It's easy to remember that phosphorus intake recommended will be roughly 50% of the calcium RDA. So the phosphorus RDA is 700 to 115 milligram per kg per day. This is quite difficult to meet with unfortified mother's milk because you all know that even preterm EBM 100 ml contains around 25 milligrams of calcium and roughly 12 milligrams of phosphorus. So even at maximal intake of say 200 ml per kg of unfortified EBM, we will only be able to provide at 200 ml per kg per day. Also, we may only be able to provide 50 mg per kg per day of calcium and roughly half of it, 25 mg per kg per day of phosphorus. So this is way less than the RDA that is recommended. So this is one of the important objectives for fortification. Iron, the recommended intake is 2 to 3 mg per kg per day as a prophylactic iron. But when you have documented anemia of prematurity, the dose is ideally to be increased to 4 to 6 milligrams per kg per day. Now, answering the other two questions, what is standard fortification? So there are different approaches to fortification. Fortification is the process of adding HMF or human milk fortifier to EBM. This is a multi-component fortifier that provides additional calories, proteins, and micronutrients, almost all of them including vitamin A, D, calcium, phosphorus, zinc, and these days we have fortifiers which also have decoxyhexanoic acid or DHA. Now, there are different approaches to fortify EBM. The standard approach is you add standard content of fortifier to standard volume of expressed breast milk. So, adding one sachet of 1 gram to 25 ml of EBM makes it standard fortification. There are two other approaches which are called as individualized fortification. One is adjustable fortification, the other is targeted fortification. Adjustable fortification involves measurement of blood urea nitrogen levels twice weekly and targeting a BUN level of 10 to 16 milligrams per deciliter. Now, based on the BUN level, if it is lower than expected, then we increase the strength of fortification. If it is higher than expected, then we decrease the strength of fortification. For example, if you find the BUN to be 8, which is below the target level of 10 to 16, then you may increase the strength of fortification. If we are adding half strength fortification, we make it full strength. So instead of half sachet to 25 ml, you can make it full sachet to every 25 ml. If this is already going on, then it is recommended we add additional protein by giving skimmed milk protein or SMP. Now, how do we monitor growth? Growth is monitored using the intergrowth charts. Intergrowth charts are standard or prescriptive growth charts in contrast to other growth charts for preterms like Fenton's growth chart or Lubchenko's growth chart, which are descriptive growth charts or reference growth charts. The difference between these two is that standard growth charts incorporate the growth of all babies who are born under standard conditions without any risk factors that can restrict the fetal growth, such as maternal conditions, preeclampsia, diabetes, etc. Whereas the regular reference growth charts like Fenton include all mothers with heterogeneous group of conditions like PAH and diabetes who may be at high risk for delivering fetuses with abnormal growth. So we move on now to the next question. So here you can see a diagram of neurosonogram. This is the coronal view of a baby's neurosonogram. And you can see the lateral ventricles, and there is a certain dimension of the lateral ventricle that is being measured here. So question is, what is being measured here and how do we calculate this? And we have two other questions related to neurosonogram. IVH with parenchymal involvement falls under what grading of IVH is something we have to answer now. Then periventricular cystic lesions extending into white matter. What is the grade of PVL? So let us take them one by one. So the measurement that we saw here is something called Levin's index or ventricular index, which is the distance between the falx cerebri and the lateral wall of the anterior horn of the lateral ventricle taken in the coronal plane at the level of the third ventricle. So this is very important. The ventricular index is used for identifying babies with hydrocephalus or lateral ventricular dilatation. It is important to measure this by doing a coronal view at the level of the third ventricle, because you can have multiple cuts in the coronal view at various points. So based on the cut, if you have a very frontally placed cut, you may only be able to see the frontal horn of the lateral ventricle, whereas you may have a very occipitally placed cut where you can see only the occipital horn. So it is important that we measure the Levin's index or ventricular index in the cut that also has the third ventricle in the image. Now, grading of IVH and PVL, important for pediatric and neonatal postgraduates. Now, IVH can be graded in two ways using the there is an ultrasound system which is called Volpace, and there is a CT based grading system called as Papillase. In the ultrasound graded system, we use the percentage of the volume occupied by the lateral ventricle by the bleed to categorize it. So if the bleed is seen to occupy less than 10% of the lateral ventricular volume in the parasagittal view, it is called as grade 1 IVH. Bleed occupying 10 to 50% in the parasagittal view is grade 2 IVH, and anything more than 50% of the lateral ventricular volume is said to denote grade 3 IVH. In the Papillase or CT based system, we have 4 grades 1, 2, 3, and 4 for IVH. Grade 1 refers to the presence of merely germinal matrix hemorrhage. Grade 2 refers to presence of intraventricular hemorrhage without lateral ventricular dilatation. Grade 3 refers to intraventricular or IVH with lateral ventricular dilatation. And grade 4 represents IVH with parenchymal extension. So the question here is, if you have IVH with echogenicity in the parenchyma, what grade does it fall under? It falls under grade 4. Note that this parenchymal echogenicity need not necessarily imply parenchymal bleeding. In fact, it is most often due to something called PVHI, which is periventricular hemorrhagic infarction. So this is a hemorrhagic infarct or a venous infarct which is caused because of the compression of the terminal vein when it takes a U-shaped bend whenever there is a large IVH that is present. So this is actually because of the large IVH causing obstruction at the level of the terminal vein, which is a tributary into the great vein, deep cerebral vein, and great vein of Galen. So this leads to venous hemorrhagic infarction or PVHI, which is seen as a parenchymal echogenicity. And it's not really a real extension of the intraventricular bleed. The other question was, what is the grading of periventricular leukomalacia cis extending into the white matter? So this is grade 4 PVL. PVL classification or grading is given by Linda DeVries, where we categorize the minor grade, that is periventricular flaring is graded as grade 1, and cystic PVL is graded as grade 3 or 4 depending upon its extension. When you have extensive multicystic encephalomalacia, this is usually graded as grade 4 PVL. Now, name one condition where the resistive index is low. So what is resistive index first of all? So resistive index is denoted, is usually measured in the anterior cerebral artery, because this is the most preferred vessel for measuring most of the indices like pulsatility index, PI, and resistive index, which is RI. So the resistive index is measured by the ratio of the peak systolic velocity divided by peak systolic minus the end diastolic velocity. So this is a ratio which when measured from the cerebral vessels, as I told you, usually we measure this in the ACA because the angle of insolation is pretty low. And this is a marker of the cerebral perfusion or the resistance offered to the cerebral vessels. So usually resistive index can go high when we have conditions like post-hemorrhagic hydrocephalus, and an increased RA is also used for um, assessment of indication to intervene in post-hemorrhagic hydrocephalus. So usually if RA is more than 0.9 or if there is a 30% increase in RA from the baseline, in addition to Levin's index or ventricular index showing or suggesting hydrocephalus, then we take it as an indication for intervention. On the other hand, RA can be low when there is asphyxia and loss of autoregulation. So where there is excessive cerebral vasodilatation, the resistive index can actually come down. This happens because of the increase in the end diastolic velocity. The next question is about one of the commonly used equipment in the NICU. So we all know that this figure shows a pulse oximeter. Questions are, we are going to discuss what is the principle of pulse oximetry, the clinical applications of a pulse oximeter, situations in which pulse oximetry is unreliable. We'll be discussing something about the alarm limits and saturation targets for preterm babies and what is considered as pass in pulse oximetry screening for critical congenital heart disease. So pulse oximetry is a very vital equipment in the NICU. It is based on the Beer-Lambert law. So this is a law which helps us to assess the concentration of a gradient or an analyte based on the absorption of a certain wavelength of light. The pulse oximeter operates by the relative absorption of reduced and oxygenated, the absorption of red and infrared lights by the reduced and the oxygenated hemoglobin fragments in the blood. So by measuring the percentage or proportion of red to infrared light spectrum in the absorbed spectrum of light, we infer how much has been absorbed and we infer the concentration of the analyte in question. And here it is oxygenated hemoglobin. So we can get the percentage or proportion of oxygenated hemoglobin as a percentage. So the clinical applications of pulse oximetry are that this is considered as a fifth vital sign after TABC. After temperature, respiratory rate, heart rate, blood pressure, the saturation is often considered as the vital sign, fifth vital sign in neonatal units. It is often used in neonatal resuscitation where we have minute-specific SpO2 targets, pre-rectal SpO2 targets, starting from 60 to 65% at 1 minute until 85 to 95% at 10 minutes after birth. It is also used for the titration of oxygen concentration with a blender, for providing posture pressure ventilation or for providing supplemental respiratory support. It is also used as an apnea monitor to detect apneas in preterm infants, for neonatal transport, and also is used as a screening tool for congenital heart disease. There are some situations where pulse oximetry is limited, has limited application, including the low perfusion states like shock, dyshemoglobinemia, like presence of carboxy hemoglobin or presence of methemoglobin, the use of aniline dyes and pigments, nail polish, optical interference under phototherapy or with bright light, movement artifacts of a baby who is irritable, and it also suffers from poor description at the upper end of the saturation. So beyond 94-95%, it is very insensitive to detect hyperoxia. Target saturation in a preterm infant is taken as, you could say 91 to 95%. 90 to 95% is also considered correct generally. And the alarm limits are set at 2 to 3% lower and 2 to 3% higher than the lower and the higher limit respectively when we are trying to set alarm limits in the monitors. Now, in pulse oximetry screening for critical congenital heart disease, this is a vital step in screening before we discharge every normal well newborn. So how do you do this? You do this by connecting the pulse oximeter to the preductal limb, which is right hand, and to postductal limb, which is either foot. And the ideal time for doing pulse oximetry screening must be after 24 hours of postnatal age or just before discharge if we are discharging the baby later than 24 hours. Now, if you find that the preductal saturations are more than 94%, and if the difference between pre and postductal saturations is less than 3%, less than equal to 3%, then this is considered as normal pulse oximetry screening or pass. Any baby who has saturation difference between pre-post rectal limbs beyond 3%, that is 4% or greater, or if the saturations are straightaway less than 90% in either limb, or if it is consistently between 90 to 94%, then it is taken as fail or refer. And in some situations, we repeat it. If saturations are straightaway less than 90%, we straightaway should refer the baby for a pediatric cardiologist opinion or evaluation with the echocardiogram. Now, conditions that can often be picked up with this are critical cyanotic congenital heart disease like duct-dependent pulmonary circulation, or admixture lesions like transposition of great arteries. But some lesions, such as coarctation, that is left-sided obstructive lesions, can be missed by pulse oximetry screening. Also, large left to right shunts like ventricular septal defect (PDA) may be missed by pulse oximetry screening because these do not impact the saturations until and unless they result in severe cardiac failure. Okay, the next question is a echo-based question. So a lot of us would be doing functional bedside echo. Now this is a parametric which is measured in a specific view called as M-mode parasternal view when we have a baby with a large PD. So questions are, what is this index? Name the index. What does it measure? And how do you define significance of PDA based on this parameter? So this is a metric or a ratio called LA by AO ratio. It signifies the ratio between the left atrial volume or left atrial dimension divided by the aortic root diameter. So this is measured in the M mode parasternal view. It's also called as long axis parasternal view or the LAPS view. In this particular view, we measure the ratio of LA by AO by using the M mode echocardiography. What does it mean? So this means that there is left heart volume overloading. So wherever you get left atrial or left ventricular dilatation because of increased volume entering the left heart, we would see that the LA-AO ratio is a good index for measuring this. Now, in preterm infants, this often happens with a hemodynamically significant PDA because the PDA is often shunting left to right and carries increased blood volume to the pulmonary vascular bed, and this is returned back into the left atrium. So particularly in a HSPDA, less than 1.4 LA/AO ratio is taken as normal, or it shows a relatively insignificant PDA. 1.4 to 1.6 is moderate, and anything more than 1.6 is said to indicate a very large or hemodynamically significant PDA. There are some other metrics which we also measure for a HSPDA, and one of them is the mitral valve E by A ratio. The mitral valve E by A ratio, E indicate the blood flow across the mitral valve during the passive filling phase, and A wave indicates the blood flow across the mitral valve during the atrial systolic phase. So a preterm infant without a PDA would generally have a E by A ratio which is less than 1, indicating that because of existing diastolic dysfunction, the A wave contributes to more ventricular filling. Whereas when a preterm baby has a large PDA, they tend to have increased or elevated left atrial pressure, resulting in earlier mitral valve opening, and this drives the early passive filling, which results in a shortened isovolumic relaxation time also, that is IVRT, which becomes less than 40 milliseconds, and it also results in a pseudo-normalization of the E by A ratio, which becomes greater than 1. So a greater proportion of the ventricular filling is contributed by the passive blood flow during the ventricular diastole. So E by A ratio more than 1 or pseudo-normalization is also a sign of a large PDA, and likewise LA by AO ratio more than 1.6 is also one of the important signs of a hemodynamically significant PDA. Moving on now to the next OSCE. This is a X-ray based OSCE. So this is an abdomen X-ray of a newborn where you can see dilated bubble loops, and there are two black arrows that indicate a specific finding. What is this finding? So if you look closely, you can see that there is intramural air, which is called as pneumatosis intestinalis. There are some other named signs to indicate this, such as signet ring appearance or tram track appearance, etc. So this is X-ray of a baby with necrotizing enterocolitis, and this specific sign of pneumatosis intestinalis is seen with stage 2A of NEC. So we shall be seeing the staging of NEC. So this is the modified Bell's staging. wherein stage 1 refers to the presence of suspect NEC, and the radiological finding in both 1A and 1B would be merely the presence of dilated bowel loops. In 1B, you get the additional finding of gross or macroscopic blood per rectum or blood in stool. But this sign has very poor specificity for NEC because mere presence of NG tube in the bowel can also lead to some blood in stool. Stage 2 is indicative of definite NEC, among which you have 2A and 2B again. In 2A, we see intramural air or pneumatosis intestinalis, as we saw in this X-ray. And in 2B, we see the additional finding of pneumobilia or portal venous gas. So in both these stages, the newborn has clinical signs or systemic signs of instability, such as hypotension, recurrent apneas, bradycardia, and the baby also has local signs like abdomen distension, pre-feed residuals, vomiting, etc. Stage 3 is indicative of advanced NEC. Advanced NEC again has two sub-stages, 3A and 3B. In 3A, we would see the finding of ascites, which is because of the transmural necrosis, although there is no frank perforation yet. In 3B, we would be able to see frank air under the diaphragm, which is indicative of perforation peritonitis. So this is the modified Bell's staging. It is a modification of the Bell staging of necrotizing enterocolitis, and it helps us based on the abdomen X-ray signs, clinical signs. It also gives us a guidance about the number of days of enteral fasting recommended in different stages. Usually in stage 1, 48 to 72 hours of enteral fasting would suffice. In stage 2A, at least 5 to 7 days of NPO is recommended, whereas in stage 2B, this is further increased to 7 to 10 days. In stage 3, the duration of NPO or fasting required would be longer, generally around 10 to 14 days minimum. Two interventions related to feeding that are known to decrease the risk of NEC are the use of mother's own milk or breast milk feeding. Whenever mother's own milk is unavailable, the use of pasteurized human donor milk, PHDM, is also found to be effective intervention to reduce the risk of NEC. The other important evidence-proven strategy for reducing NEC risk is the use of probiotics. There are multiple papers on the dose and the type of strains to be used in probiotics. Usually, we recommend a dose of 3 billion spores as a combination of at least 2 strains of lactobacillus, bifidobacterium, and at least 1 strain of Saccharomyces. A multi-strain combination of probiotic is found to be much more useful than a single strain probiotic preparation. However, this must be combined with other useful evidence-based strategies, particularly the use of early enteral feeding strategy, the aggressive escalation of advancement of feeding, use of mother's own milk or pasteurized human donor milk whenever unavailable, and limiting the use of prolonged empirical antibiotic courses. All these must be practiced in addition to probiotics to reduce the risk of NEC. Next OSCE is based on statistics. So this figure is something I'm sure most of you would have seen. It is a forest plot that is used in a systematic review or meta-analysis. So what are the following what are the following parts in the forest plot and what do they imply? That is the question. So whatever is being circled, we'll have to identify what it means. So this is a forest plot. It is comparing hypothermia versus normothermia for a certain outcome. The outcome is not mentioned. This is most likely a forest plot of therapeutic hypothermia versus regular care in the treatment of newborns with perinatal asphyxia, and is probably looking at the outcome of death or death and HIE as a composite outcome. So you can see that each individual study is given here with the year of publication. These are the events and the total number of subjects in the hypothermia arm in these individual randomized controlled trials, and likewise the events and the total number of infants in the normothermia arm. The weightage of each study is indicated also as a percentage based on the sample size, and each study's risk ratio or point estimate of the risk ratio and its 95% confidence interval is given in figures here. And then on the right extreme, you can see that the point estimate of each study is represented by a square or a rectangle, and the 95% confidence intervals by a line around the square. At the end of the forest plot, you find the cumulative or the pooled relative risk indicated by a diamond. The center of the diamond indicates the pooled relative risk, and the two ends of the diamond indicate the 95% confidence interval of the pooled relative risk. So this is the forest plot. So the first oval circle that is being highlighted is actually referring to the pooled relative risk of the entire forest plot. It is actually a weighted average of the relative risks of the individual studies. The center of this diamond indicates the pooled RR per se, and the corners and the two horizontal corners of the diamond indicate the 95% confidence interval of this pooled relative risk. So if this entire diamond is lying to one side of the line of null effect or the line of RR equal to 1, then this indicates a statistically significant effect of the intervention on the outcome of interest. On the other hand, if the diamond is crossing the line of null effect, then it means that the intervention has no significant impact on the outcome of interest. Now, this second circle that is highlighted, it indicates the point estimate of relative risk of the individual RCTs. So, two individual RCTs are represented here, the first and second. You can see that the right-hand corner of the 95% confidence interval line is just touching or just crossing the line of null effect in both these RCTs, indicating that in these two RCTs, the intervention did not have a significant reduction in the outcome of interest. The third parameter that is highlighted here is something called I-square. I-square is an index of the heterogeneity of studies in a meta-analysis. So when you say we are doing a meta-analysis, we are actually combining multiple studies which may have similarities, which may also have some dissimilarities. So I-square is a parameter to measure this heterogeneity or differences among these individual studied RCTs. Ideally, when the heterogeneity is minimal, the forest plot conveys more meaning. But there are different statistical methods to analyze forest plots when studies have higher heterogeneity. So generally, if I-square is below 50 to 60%, we can straight away use the fixed effects model for performing the meta-analysis. If it is elevated to more than 60%, we use something called as a random effects model to perform the meta-analysis. So here I-square is 0%, indicating that all the studies have fairly good homogeneity. And they had very little difference with regards to the population characteristics or with regards to the intervention studied, etc. So that's what it is. And this is the implication of the different aspects of the forest plot. Now we have a question on community neonatology. So let us see what is the NMR, EMR, ENMR and IMR of India. Sorry that this question is as per 2013 SRS, but the answer is actually updated. It is as per SRS 2020. So this is the overall NMR now today in India stands at 20 per 1,000 live births. It's come down significantly in the last around 20 years. And the early NMR is at 15, which means deaths within the first 1 week itself are 15 out of the 20 neonatal deaths per 1,000 live borns. Late NMR is only 5. So between the end of first week to fourth week, there are 5 more additional deaths per 1,000 live borns, giving a total NMR of 20. And infant mortality rate, that is mortality less than 1 year, stands at 28 per 1,000 live births. Going one step further, the under 5 mortality rate or child mortality rate is 32 per 1,000. States which have the most and the least NMR in India are Odisha and Kerala. Kerala has been having single digit NMR for a very long time now. It's at around 6 per 1,000. Delhi, Tamil Nadu and Goa also have single digit NMR. The most common cause of neonatal mortality in India is prematurity, which is followed by sepsis and asphyxia. The next question again is on statistics. So this is the main primary outcome table in a RCT that was comparing probiotic and placebo in the incidence of NEC. So question is, RCT was performed to evaluate the effect of probiotic on incidence of NEC following as the primary outcome. So NEC occurred in 1 out of the 50 infants in the probiotic group, and it occurred in 5 out of the 50 infants in placebo group. So question is, how do you calculate the NNT? So to calculate NNT, we need absolute risk difference. So relative risk and absolute risk difference are two important things we should know. Relative risk is incidence of events in the exposed divided by incidence of the outcome or events in the unexposed. So here exposed or the probiotic group were 50 total. A plus B is 50, and events or incidence of outcome was only 1. So 1 out of 50 in the numerator divided by 5 events in the placebo group divided by 50 denominator. So 1 by 50 divided by 5 by 50, which gives 1 by 5, and that is 0.20 is the relative risk. This is relative risk of occurrence of NEC in probiotic arm versus placebo arm. The absolute risk difference is nothing but A by A plus B minus C by C plus D. So if you divide A by A plus B by C by C plus D, you are getting relative risk, which is a ratio. Whereas if you subtract one from the other, we get the absolute risk difference. This is also called absolute risk reduction, ARR. So A by A plus B was 1 divided by 50. C by C plus D, as we saw, was 5 divided by 50. So the difference is minus 4 divided by 50, which is minus 0.8. If we divide 1 by absolute risk reduction, which in this case is 1 by 0.08, you can ignore minus in this particular division. Then we get the number needed to treat. So NNT is the number of subjects which are to be treated by the intervention in order to get one meaningful difference in the outcome. And this is 1 by 0.08, which is around 13 infants rounded up. Next OSCE is also on statistics. This is going to be discussing the various tests of significance for different types of studies. So, weight gain over the first 10 days after birth is compared among babies fed with mother's expressed milk, babies fed with donor milk, and babies fed with formula feeding. So there are 3 groups here, and we are going to compare weight gain over the first 10 days after the birth. So this is a numerical variable. This is not a categorical variable. So what test of significance will you use when you have a numerical variable in 3 groups? So if it had been 2 groups, we would have used simple t-test. Because we have 3 groups, we are using ANOVA, which is analysis of variance. Next question, you want to compare the birth weight and weight 10 days after birth in a group of preterm infants. So this is just a single group, and we are going to compare birth weight and date and weight for the same subject. So this is something which is little different. You don't have comparison of 2 groups of babies. In the same group of babies, you are going to measure weight at 2 points of time. So this is paired t-test that we are going to use. So paired t-test is used when we have in the same subject 2 measurements. And this is because this is a single group with the same subject where you're taking 2 different measurements. Next question. A study is being performed to test an intervention that occurs prenatally to improve neonatal transition right after delivery. The main outcome variable is the Apgar score at 5 months. At 5 minutes, at 5 minutes. So you have, there must be an intervention group and a control group. So this sounds like a RCT, but the intervention, the outcome that we are studying happens to be Apgar score at 5 minutes, which is a non-parametric numerical variable. So if it's a parametric or a normally distributed numerical variable, we could have used again the t-test. But because this is a non-parametric test where Apgar score is the main outcome, we would prefer to use the Mann-Whitney test or a non-parametric test. Next question, study on the impact of type of feeds and the presence or absence of NEC. So we are going to have 2 arms, 2 types of feed, and in each arm you are going to study the incidence of NEC. So we are going to compare 2 different proportions, the human milk fed group and the formula fed group. So this is going to be chi-square test. So wherever you are comparing proportions in 2 different groups or in multiple groups also, we are going to use chi-square test. So this outcome is not a numerical outcome. It is just a yes or a no variable wherein we are going to see whether NEC occurred or whether it didn't occur. Next question, birth weight is compared with weight on day 10, day 20, day 30 and day 40 and weight at discharge among three groups of babies, breastfed, donor milk fed and formula fed babies. So you have three groups and you have five different points of time wherein you are measuring the weight for the same baby. So this is a variable, this is a test called repeated measures ANOVA because you have multiple measures taken in the same subject over a period of time. So we discussed different types of tests, chi-square test to compare categorical or non-numerical variables. Numerical variables in two groups can be compared using simple t-test if they are normally distributed. If they are non-parametric numerical variables, we use Mann-Whitney test. If we have more than two groups, then we use something called ANOVA if they are normally distributed. Again, if they are not normally distributed numerical variables more than two groups, then we have to use Kruskal-Wallis test. So this is the last OSCE for the day. This is on performance of a diagnostic test, sensitivity, specificity, and all that. So a new test is being performed to screen 100 neonates at risk for sepsis. Let us say we are performing CRP. 50 of them tested positive with this test. However, only 40 infants tested positive with the gold standard test, which is blood culture. So these are the true positives. 8 infants who tested negative with the test A turned out to be blood culture positive. So although these infants tested negative with the new test, they were actually blood culture positive. Now we have to calculate sensitivity, specificity, PPV and NPV for the test A. So for questions like this, the first step we must do is to construct the 2 by 2 table. And remember the two top columns in the 2 by 2 table must always be true positive and true negative. In this case, it is blood culture positive and blood culture negative. The two rows will indicate the test positive and the test negative. And we already know that the total test positives were 50 out of the 100 infants tested. What we also know is that 8 infants who tested negative ended up being culture positive. So these were all the infants which were missed by the new test. So now you can fill in the other cells in this 2 by 2 table. You know that the first, the column of blood culture positives adds up to 40. So when we know that the column C labeled as C is 8, we automatically know that A must be 32 because 32 plus 8 is 40. We also know that test A total positives were 50, of which 32 were true culture positives and the remaining must have been culture negative but test A positive. So this is 18. This leaves us 42 in the last cell. So let's now calculate all the four metrics of significance for us: sensitivity, specificity, positive and negative predictive value. So what is sensitivity? Sensitivity refers to A by A plus C. So this is among all the true positives, how many actually tested positive in the test. So among the blood culture positives, how many tested truly positive with our new test? And specificity means among the blood culture negatives, that is true negatives, how many tested truly negative with your test, which is D by B plus D. So sensitivity is 32 by 40, which is 80%. And specificity is D by B plus D, which is 42 divided by 60, which is 70%. The positive and negative predictive value, on the other hand, will have the test positive and test negative in the denominator. So among all the test positives, which is 50, how many were truly positive? That is A by A plus B. That is positive predictive value, 32 by 50, which is 64%. Likewise, negative predictive value means among all the test negatives, how many were truly negative? So D by C plus D, which is 42 by 50, 84%. So I think I'll end here on the second class on OSCEs in neonatology. And thank you all once again for joining us. If you have any questions or comments, please feel free to share it with us. And we'll be meeting you again for the next session of Cuddles online session on coming Friday, 2 to 3 p.m. with another interesting topic. Thank you everyone who has joined us. See you. Bye-bye.